Sweet. All right. Hey, guys, thanks for showing up. Welcome to EMS Challenge. Thank you guys for hosting us today. We're live at the EMA. Couple of updates. We will be at Enterprise Rescue at end of the month in Monroeville. We also are starting in July our SIM competition training. So, the state conference does their SIM competition. So first round, if you want to move to the second round, you can do the first round checkoffs with us at EMS Challenge. So starting in July, if you want to come out, we've got the scenarios written up and how we're going to grade those for the state. We'll start that advertisement here probably next week, but you can come out and do that first level SIM checkoff with us to get in the running for the final round at the state conference. And I think that the winners will be getting next year's conference free, bragging rights and things of that nature. And they get a dinner with this guy as well, right? He's buying it, right? Yeah, I thought that crystal's by the airport is what I was thinking. So that's pretty nice. Cool. Critical care training, if you're interested, the State Fire College has a critical care paramedic program that's starting up. We will be partnering with that program and having clinicals that you could do at UAB for that critical care program and doing labs with them, cadaver labs and skill labs. So a lot of good things going on there. Our next cadaver lab will be in September as well. And I'll post those dates on the flyer for EMS Challenge. So cool. All right. I'll leave you alone. Dr. Sullivan.
All right. Good morning. Cases in resuscitation, installment like number 10. So we've been through most probably cases that you're going to see on a routine basis. The ones that are left are like things that you might see once every couple of years. So we're going back through some that you've probably seen from me too. I know you've seen a couple of these, similar type cases from me. So forgive me for kind of rehashing some things, but these are hopefully some high yield cases to run through that you're going to see all the time, right? We'll talk about like pathophysiology and things of that nature. We'll talk about some pharmacology and stuff like that. But for this one, I wanted to build in a little bit of kind of the next step and kind of next level of thinking, and that's broadening like a differential diagnosis, right? So we're really good at recognizing general patterns of things that are going on and saying like, I think this is, some kind of reactive airway disease, or I think this is a heart attack or whatever. But there's some area in here to kind of talk through some differentials and start thinking about like, hey, I have this patient who's in respiratory distress. Am I thinking through all the things that can look like this? Is this COPD? Is this asthma, pneumonia, a pneumothorax, tamponade, PE, MI, NSTEMI, things like that. So take an approach to this to where you're thinking through the cases themselves. You're thinking about what you would do, thinking about how to follow your protocols and the things that you're trained to do from that standpoint, but also like considering the things that this may be, right? In some ways that you could be misled and could be overlooking some things. So we'll rock and roll through all of this real quick. The biggest thing to kind of emphasize when we talk about cases in resuscitation is treating physiology, right? We can give folks we have limited interventions in the pre-hospital setting, but the most important thing is to recognize like why does a patient look the way that they do? Why are they having trouble breathing? Why are they having chest pain? Why is their neurologic exam terrible? Why does this look like a stroke but doesn't really match up like it's a full-fledged, large vessel occlusion? This doesn't make sense. So start to think about kind of the physiologic process behind why people look the way that they do. And we'll try to talk through some of those. So this is your first patient. You call us for shortness of breath. So you were dispatched and arrive on scene of a 68-year-old male with shortness of breath. His wife meets you at the door, says he's been getting sicker over the last 3 days. He's had maybe some fever, some cough, worsening fatigue, starting to look a little pale today. So you get inside. He's sitting upright on the edge of the bed. He's leaning forward, so he's kind of like tripoding, right? He's really trying to take some pressure off of his chest. He speaks in 2 to 3 word sentences. His skin is cool and sweaty, and you hear a bunch of wheezing from across the room before you even touch the guy. So his vitals are heart rate 124. It's kind of bouncing around and variable. His blood pressure is 168/94. His respiratory rate's 34. SpO2 is 83% on room area. Does not wear oxygen at baseline. So he's got a history of COPD, CHF, hypertension, And pertinently, he's been intubated before. As you start to put him on oxygen, he starts to get real anxious and says, like, I can't keep doing this. A really cool quote that has followed me since the beginning of medical school. Sir William Osler said, if you listen to patients for long enough, they will tell you what's wrong with them. And when somebody starts to tell you that, I feel like I'm dying, or I feel like I can't do this anymore, like I'm running out of gas, things like that, they're telling you the truth. Typically, they have this sensation of doom, so listen when they say things like that. But your differential diagnosis here, what do you think of when you think of severe shortness of breath, dyspnea, wheezing, things of that nature? What are some things that come to mind? Yes, the COPD, asthma, yeah. What else? So this guy's blood pressure was like 220, 230 systolic. Could be like hypertensive emergency, could be flash pulmonary edema, could be a CHF exacerbation, aortic dissection, pneumonia, all those things, right? So how do we get to the diagnosis? Start to take into account the full picture, right? So we take their history into account. We take their overall presentation. Is the patient warm to the touch? Does he feel like he's febrile? Does he have infectious symptoms? Does he have a history of COPD? In this case, yes. He also has a history of CHF. Does he look like a bag, like a water bag or something? His legs look like the Michelin Man. Has he been on a blood thinner and recently come off to make you think about a PE? This is where you start to take it to the next level, right? Where you're just looking at a guy with shortness of breath, and now you're taking it next. And you're like, this is what I think is actually, this is the most likely diagnosis, and this is all the things that could be going on. So this guy could be in DKA. He could be having an MI and having some hypotension or something like that. He could be having a, he could be having like a pericardial effusion that's giving him tamponade. There's a number of things. So there's building this broad sense of an understanding of how these things cross over and how things can present similarly, is taking it to the next level for you, right? And so you start to develop this, and then you put pieces of the puzzle together to decide which one is more likely versus which one is not. So moving on with the case, you put them on the monitor, and this is the strip you get. What do you see? Yeah. What are some things that you look at when you're just like quickly making a rhythm assessment? Yeah. So the way I like to look at these is kind of a simple thing is like this rule of four. So it's like, is it fast or slow? Is it narrow or wide? Is it regular or irregular? And then is the patient stable or unstable? And if you can answer those questions, you can kind of narrow down what's going on with them pretty easily. This is pretty explanatory, right? This is a narrow, complex, irregular tachycardia, which is pretty much AFib without many exceptions. So that's what this guy is in, right? So you get your EKG, that's what it looks like, or AFib RVR and occasional PVC mixed in there. So this guy, what do you think is going on with him? He's wheezy. He's got a history of CHF. He's a little swollen. This is probably a mixed picture. Ultimately, this guy is in respiratory distress, so there's some baseline things that we have to do for him, right? We got to put him on oxygen. We got to help him from that standpoint because obviously he was hypoxic when you arrived. So our initial interventions are getting the guy oxygenated, so non-rebreather, nasal cannula, however we have to do it, and then starting to consider what else is going on here. So you listen to the patient, and he's got a bunch of wheezing. So we're thinking there is some component of reactive airway disease here. So a duodeneb and things of that nature is the correct answer to start doing for this guy. Other things we have to consider is yeah, he's wheezing, but a lot of people with COPD that aren't in an exacerbation wheeze too. Does this guy need positive pressure? Does this guy need some other kind of intervention? Or your duodeneb's going to do the trick? Duodenebs and steroids and things like that. Or is the guy in DKA and having all this stuff going on, and none of this is really going to make him better until we get to the hospital and get him on an insulin drip and do all those things. So for this guy, but you have to treat what you got, right? The most critical interventions, are ABCs, airway, breathing, circulation. So you know the guy's in respiratory distress, he's hypoxic, so you put him on a non-rebreather, and starts to improve. But like I said, this is probably more of a mixed picture. And this guy's ultimately in a CHF exacerbation with some kind of upper respiratory type illness, and now he's having an exacerbation of his COPD as well. So just treating one or the other is not necessarily going to put this guy where he needs to be. So he can oxygenate. He's not doing a good job of ventilating either because of his COPD. He's starting to get fatigued. He's starting to kind of circle the drain from a respiratory standpoint, right? So what are some ways that we can address this and help him out from both a COPD and CHF standpoint? Yeah, exactly. Some non-invasive positive pressure. Very good. Both of these situations, one or the other or both, is going to benefit a lot from positive pressure. So I have a low threshold in these folks, unless they're like super unstable, to begin some positive pressure. And again, that's kind of like treating the physiology, right? We have a gas exchange issue with our COPD, so he is not getting a CO2 off. He is not getting enough oxygen into the bloodstream. So there's a gas exchange ventilation problem, and he's probably acidotic, 7.1, 7.2, something like that. With CHF, he's probably got a bunch of pulmonary edema as well. And so with the positive pressure, not only do you help with that gas exchange, but you start to use that positive pressure to open up airways, and you start to overcome what's called hydrostatic pressure. So inside the vessel, like a blood vessel itself, the ones that pass very closely to the surface and like the little airways, when you get a bunch of backup from CHF, the pressure inside those vessels increases. And so that pressure forces fluid out of the vessel and into those alveoli. And so the little airways fill up with fluid and impede gas exchange, impede oxygenation. And so once you add this positive pressure, the pressure gradient inside of those airways increases more than the hydrostatic pressure inside the vessels. And so that's how you start pushing fluid out of the lungs and back into the circulation. So if that makes any sense from that standpoint, does that make sense? How you kind of overcome the intravessel, like kind of hydrostatic pressure. So you're helping both ways here. And you help recruit more alveoli to deliver your duonebs and things that you're already doing for this guy. Since you suspect some reactive airway disease, you're pushing those medicines further into the airways. So you're doing a number of things to help yourself out. So COPD, as we kind of talked about, what is that? It's chronic obstructive pulmonary disease. Their baseline state is inflamed. So they already have these angry airways that produce more mucus than others. They're thicker than others, and they don't exchange gas as well at baseline. Anything that triggers it, so whether that's a virus, like a viral infection, upper respiratory infection, your allergies, things of that nature, and bacterial pneumonias, all very common causes, they kind of start to get you into a hyperinflammatory state, even more so than their baseline. So you start to see a lot of bronchoconstriction, so spasm of the muscles around the airways. You start to see more mucus and things get pumped out into the airway that causes more obstruction. And all of that winds up giving you a bunch of air trapping, decreased gas exchange, and you start to kind of tire out, get more acidotic, and you get more into the cycle as your kind of sympathetic tone increases throughout. What we do for that is we treat the underlying cause, but we give them those medicines, right? So we give them duonebs, ipratropium, magnesium, steroids, and things of that nature we'll talk about in just a second. For this guy, as far as CHF goes, so there's a problem with the pump. So usually it's a systolic heart failure. There are diastolic heart failures that present in the same way. But with this guy and your classic CHF type picture, it's a systolic failure. So that's failure to pump the blood forward. So what you get, like we talked about, is a bunch of back pressure of fluid that the right heart is not doing a good job of pumping through the lungs, but the left heart is not doing a good job of getting it out. So you get this compensatory mechanism where the left ventricle fills more, and as a result, you start to get more left ventricular dilation. So you get into the cycle where it makes itself worse as it tries to compensate until ultimately you get into like an end stage. and people can't compensate. And then you see people on milrinol drips at home. You see them on LVADs and things like that. But ultimately, in this guy, you get all that back up, it increases the pressure, you get a bunch of pulmonary edema, and you start to fail to perfuse the rest of your body forward as well once you get into that kind of cycle. So a lot of bad stuff going on with these folks. So our treatment here, you're going to obviously sit the guy up and find his most comfortable position. He's kind of already doing that the way you found him. We're putting him on high flow oxygen, whether that's a nasal cannula, non-rebreather, however we can make that happen, but a low threshold to begin CPAP or BiPAP. We talked about the physiology, so we're not going to rehash that, but we want to be prepared to escalate and be prepared to intervene before these folks start to really get away from you. So a little bit about our mechanisms, just to review those. Albuterol is a beta agonist. So what it does is it goes into the airways, it binds onto these beta receptors, which causes vasodilation or muscle relaxation. So it helps to kind of open the airways. There's other benefits to this, like in hyperkalemia, those beta receptors can trigger an influx of potassium into the cells, but that's another case. But ultimately, what you're getting with albuterol is a little bit of decreased inflammation, a little bit of decreased mucus and secretion production, but mainly you're getting bronchodilation. The same with ipratropium. The difference in it is it's a longer acting bronchodilator. It acts it's an anticholinergic, so rather than like a beta agonist, it inhibits cholinergic receptors and therefore kind of has the same effect. Ipratropium lasts approximately 4 to 6 hours, and the more you give of it, there's not really any added benefit. So a lot of people give Duanebs over and over and over again, which is fine. You're not wrong to do that. But the single upfront dose of ipratropium and then repeat doses of albuterol in the time that we're going to have patients pre-hospital is going to be enough. So a single upfront dose of ipratropium, make sure you give that right out the gate, but you don't really have to worry about redosing ipratropium frequently. Steroids. So Solumedrol 125 is typically the go-to dose for folks. Some people use dexamethasone or Decadron, prednisone orally, but the kind of go-to is typically Solumedrol unless your protocols differ. What it does is it upregulates beta-2 receptors, but that's not its main thing. Its main thing is actually kind of cool to me. It alters DNA and it increases the production of anti-inflammatory proteins and things like that. So it actually does some cool stuff, but it is a delayed effect. So the earlier you can give steroids, the better for these people. Now you have to be a little bit cautious and consider like the risk benefit of like, is this person sugar 400? They have DKA. Am I going to help make this worse? But ultimately, like based on your exam and your history and things of that nature, you can make a decision on whether steroids are the right move. And in most cases, in a classic COPD or asthma, it is the right move. Other things, magnesium, we give 2 grams usually pretty quickly, somewhere between like 15 and 30 minutes via IV, usually 2 grams. And it is also kind of a potentiator of the other effects. It helps upregulate beta receptors, and it also causes a lot of decreased inflammation as well. So the magnesium is more to potentiate like your albuterol treatments and help from that standpoint. A lot of times people will benefit from epi if you have super refractive COPD, particularly asthma in kids. An IM dose of epinephrine is not wrong in these guys, especially asthma exacerbations. If you have a kid that's real sick with asthma or something along those lines, and you can't really get them to turn around with just your nebs, considering a dose of IM epi is a really good move, and a good move early, because it hits alpha and beta receptors, and really does a good job of helping potentiate this whole milieu of things that we got going on. But epinephrine, smart move, particularly in refractive asthma. And then, not necessarily like for you guys, I don't know how often y'all are given Lasix in the field, but ultimately a lot of these heart failure guys have to have some kind of diuretic. Typical doses up front without knowing the patient's history are like 20 to 40 milligrams IV. The way we do it in the emergency department is typically like 1.5 to 2 times a dose of their home dose. So if the patient is taking 40, I usually give them 80. If they're taking 40 twice a day, a lot of times I'll give them like 120. So I'll give them pretty big doses. Lasix is interesting in that it is they call it Lasix. Anybody know why they call it Lasix? Lasix lasts 6 hours after its dose, interestingly. That's its half-life. And Lasix is a threshold drug. So you give that, people have their threshold that they respond to. So if you give like 180, but their threshold is 40, you're not going to do yourself any better than if you just gave them 60. So knowing where these people respond is helpful. But you want to get up over that for sure, because if you underdose and you don't meet that, you're not going to get the response you want. But a lot of the Lasix is kind of department dependent and based on what your protocols are. And if you give that routine, because it's not a drug that's without consequences, it's not friendly to kidneys. So there's a risk benefit to that as well. A little more about positive pressure. I like the schematic just because it kind of shows what it's doing in the lungs. And I like simple things. I don't like big complex things. I like to see pluses and minuses and for things that just tell me straight up what they're doing. But this is kind of from top to bottom what you're going to see with your positive pressure, right? So you're going to split the airway open. So if you've got a lot of swelling and things like that, you're going to help move air better than just the negative pressure that a patient's going to generate with their muscles. You're going to get more positive intrathoracic pressure. So like we talked about, so you're decreasing your venous return, which can be an issue when it comes to like an unstable and hypotensive patient. We particularly worry about these in like a septic patient that's needing an airway, but they're hypotensive, or a trauma patient who is bleeding out and hypotensive, or a trauma patient with a pneumothorax. If we go adding a bunch of positive pressure in there and taking away the preload that they're depending on, that can be an issue. So knowing what kind of physiology, right, that you're dealing with before you start adding positive pressure and increasing the pressure in someone's chest is extremely important. So you increase your lung volume, you recruit more airways, right? So you recruit more alveoli to exchange gas and to help you out. You increase your cardiac output by helping push out. So you kind of decrease or you rise up the pressure to help meet your systemic vascular resistance. So lots of good things, but there's certainly risks to be aware of, right? So if a patient is profusely vomiting, if they're not protecting their airway, if they're really, really, really altered, we'll still put people in the emergency department that are altered and sometimes like real altered on BiPAP to try to spare them a tube if we think that the tube is going to be bad for them or they're not going to come off of it. And you can really turn people around. So there's certainly a risk benefit, and you can take a little bit more risk with these than you really think. Just because a patient vomits once doesn't mean that you can't put it on them. Just because a patient's confused doesn't mean you can't put it on them. A lot of times you can spare people a tube with positive pressure. So anyway, like I'm saying, CPAP, positive pressure, is not necessarily just the last step, right? This can be an early intervention for you that can really, really benefit your patient. I like to use it early when a patient is showing me any signs that this might be kind of a prolonged resuscitation or that they might not respond. I like to slap it on them. If they can tolerate it, it's usually helpful. Use it with caution, but know that you can take some risk with this. A lot of times intubation is riskier than the thought of like a potential aspiration if they vomited. You can put it on altered mental status patients if you can effectively ventilate them that way. So there are things that make you worried, but there's certainly benefit. And I took this straight from Stat Pearls. If you ever want good, solid reviews of various things, I think Stat Pearls is a great way that they break things down. And they actually have a lot of things on specifically pre-hospital treatment of various things. And this is directly from pre-hospital CPAP and BiPAP. And basically it says that all these meta-analyses that we've done recently show that non-invasive positive pressure ventilation significantly enhances patient outcomes. So you starting it early in the field has a demonstrable effect on whether or not the patient's going to leave the hospital. So do consider those things early. Any questions about those? That was kind of a lot of information for one case.
Hey, Doc, we got one question about the threshold effect for Lasix.
Yeah.
So why do we start so low? It seems like if we don't really know what the patient's threshold is.
Well, so that's a good question. And that kind of brings up the question of like, is it really useful for us to start outside the hospital? Usually it's because, Lasix carries a lot of, I guess, real, how am I trying to say this? How severe it is, nephrotoxic and things like that. Or are you gonna diurese a patient? Are you gonna initiate diuresis without really knowing whether or not they're intravascular volume up? I guess people are just cautious with it because it is nephrotoxic and it does carry the risk of making things worse. If you were to look at somebody and their legs are swollen or whatever, and you're like, oh, this patient's clearly volume overloaded, but in reality, they may just have liver dysfunction or kidney dysfunction, be very intravascularly depleted, already have a severe AKI that we don't know about. And then you give them Lasix on top of that. And so now you've started, a diuresis process that you can't really stop. You can put more back in, but what I would say is maybe the question is like, is it really worth, especially if we're giving super low doses, is it really worth giving if we're only going to have the patient for 20 or 30 minutes? Is 20 to 30 minutes earlier diuresis going to be the thing that benefits them? I think that's pretty low on the threshold. And so I'm skirting around the question of why we start low. I don't really know. I think it's more out of caution.
There's been a change in that over a long period of time. Many years ago in EMS, we would give, if the patient was taking Lasix at home, we'd start them out at 80, even though the protocol said 40.
Yeah.
And that was with online medical direction. And that was before we had CPAP available pre-hospital. It did seem to help. And we were always told that patients, quote, built up a tolerance if they took it all the time. I'm not sure that that's actually true. I guess that's kind of what I'm asking. Is there a tolerance like you would get with some other drugs, or is it just this straight threshold drug that we have to?
People do, as they move along with heart failure, wound up with increasing doses. So you'll see people started at 20 and then they go to 40 and then they go to 80 and then they go to 80 twice a day. And then they go to whatever, and then they go to Bumex, and then they add all this stuff. And so eventually you get up to where like a patient is like, I'm taking 2 of Bumex 2 times a day, which is like 360 milligrams of Lasix or something like that. So there is some component, like whether it's like resistance or tolerance or whatever, or is it that they're living with heart failure and they're getting worse and they do a worse and worse job of compensating and need more diuresis. That threshold does seem to increase over time. And so as people take those drugs, for whatever reason, whether it's tolerance or whatever, that tolerance or that level of effectiveness does seem to increase and they require increasing doses. Which is specifically why I mentioned, like, I don't have like a dose to where like a patient comes in and I say, oh, we're going to give them this. That's why I ask directly, like, how much Lasix do you take? And then I give them that 1.5 to 2 times dose.
So really, if we're thinking they're fluid overloaded and we've got cardiac involvement,
Mhm.
so really the main objective should be vasodilation coupled with positive pressure in the airways to splint them open.
Yeah, I think Lasix is way down on the priority list for us,
Gotcha.
but can be used. Anything else? Cool. Pediatrics. Everyone's favorite. 3-year-old male, trouble breathing. Mother meets you at the door. She's holding her kid. She said he's had a runny nose and a cough for a couple of days, but stopped wanting to eat, became more irritable, and started breathing with his belly. It's all ominous things. He's awake, but he looks like he's tired. There's nasal flaring. There's intercostal retractions. He has a very weak cry. Skin's warm. He has a perioral pallor, so a little bit of like maybe a little blue tinge around his mouth. His initial vitals, he's tachycardic 168. His respiratory rate's 46. His SpO2 is 89. His temperature is 101.8. You hear diffuse wheezing, decreased air movement at the bases. As you begin your treatment, he becomes quieter. He becomes less resistant to you doing things. You decide to put in an IV, and he doesn't do much. Some bad signs, right? So what do you think would be going on with this kid? Yeah. So he's either got some underlying asthma that's being triggered by a URI. He's got bronchiolitis. He's got something going on that's given him kind of a similar process to the patient before, right? But now this is a pediatric version. So a few different things we have to think about in a kid like this. Obviously, this vignette is a little more slam dunk for an infectious and reactive airway process. But you do have to realize that in a kid in respiratory distress, there are some other things that you have to start considering. So what are the big things, particularly for kids? Obviously, bronchiolitis is probably our leading diagnosis here, right? But you have to start thinking about in a 3-year-old, like a foreign body aspiration. Is this a toxic ingestion? Did he get into like mom's aspirin? Did he get into mom's whatever? And take a bunch of those, and now he has an acidosis because of his medications. Is this his first presentation with DKA? Like, is the kid actually in diabetic ketoacidosis for the first time because he's a diabetic, type 1 diabetic, and we didn't know? Does he have congenital heart disease? Does he have a shunt somewhere? Does he have like a ASD or a VSD that is now reversed? Does he have some kind of heart failure? Does he have myocarditis? So there's a few other things with kids that you have to start thinking about that's a little bit different from the adult side. Epiglottitis is more common in this group, croup, things of that nature. So a few other things that we have to start thinking about. So this kid is in respiratory distress as well. And as we described in the vignette, he starts to kind of decompensate and head towards more full-fledged respiratory failure. So the big things we think about in kids, particularly with like a respiratory distress and a reactive airway, some wheezing and things like that. We look at kind of their general state, just like with an adult, but more so with the kids. Are they having nasal flaring? Are they using their belly to breathe? Are they having a lot of chest wall movement? When you listen to their chest, do they have loud wheezes, which can be sometimes in a way a good thing, or do you not hear much at all? Is the kid resistant to what you're doing to him? He's 3 years old and you're a stranger at his house trying to put things on him, put stickers on him, and maybe even put in an IV. A normal kid should be freaking out when that happens. Is he just laying there and letting you do it? Those can be ominous signs, right? So for you, with an impending respiratory failure, imminent respiratory failure, whatever, you have to be a little more prepared than even with your older population to go harder than you would otherwise. So kids, not small adults. That's the most worn out thing that has ever come along with anyone trying to teach pediatrics, but it is very true. Their physiology is different. The way that they compensate until the very last minute is different. They are just different. So they have a smaller airway diameter. So things are more prone to obstruction, whether that's a foreign body, whether that's secretions, mucus plugging. They are much more prone to go south by obstructing than your adult population. They interestingly consume oxygen at a higher rate. Their basal metabolic rate is higher. They can hold on for longer when they're hypoxic, but they have a little bit more demand. And so once you take that away from them, they compensate for a while, and it's another reason why they kind of fall off the cliff very quickly. They have less respiratory reserve, the little bitty ones, because of their lung sizes. When they fatigue hard. Same thing. It's all like this big compensatory deal. It's like a young person who's shot and bleeding out, right? They stay fine. Their vital signs can look somewhat fine for much, much longer than the adults. A big ominous physiologic sign from a vital sign standpoint is if you have a kid who's tachycardic and then becomes bradycardic and less responsive. Like that is the sign of an imminent arrest. So most of these start as like your classic upper respiratory symptoms or like a basic run-of-the-mill exacerbation, but they fall off the hill very quickly and can fall into an arrest a lot faster than you would expect. So as we said, signs of failure: decreased mental status, poor respiratory effort, severe hypoxia, bradycardia. The kid is exhausted. He's not doing much. He's less responsive and less resistant to your exam. So how do we escalate these kids? Once you start to get like a lethargic, less responsive kid with an airway issue, initiate your BVM quick, like earlier. Use appropriate pediatric equipment. So have the things that are handy that can help you select those two. It's not easy when you're dealing with a really sick kid to remember all of the things and dosages and sizes and things of that nature. So having an external source of that information that takes away that cognitive load from you, I say it every time I talk about it, kids, is so important and will bail you out of so many situations. You know, when we're talking about bagging a kid or intervening on them, we want to make sure, because of their anatomy, bigger heads, they're more prone to collapse down and have their soft tissues fall back. Their epiglottises are bigger. There's more tissue within the upper airway. So really propping these kids up and making sure that they're in good position, using like a two-handed seal when you can, two-handed bagging technique, gentle ventilation. We can overventilate these kids a lot more. Their lung volumes are lower. So trying to avoid barotrauma and giving them a pneumothorax on top of their issues is of big importance as well. With kids, you want to be, like I said, on your toes for things, right? So if you're transporting a kid who had an issue, you want to be monitoring their vital signs all the time. You want to be reassessing these kids head to toe frequently. So if there is a sign of imminent demise, you can be on top of it. We're not going to go back and hit all those medicines like we did before because these are similar presentations. With this case, I just wanted to make sure that we understand, like, there are differences in the way we need to be thinking about things. There are differences in the way we need to develop our differentials. And there are differences in the way that we need to manage these patients because of their compensatory mechanisms and because of the things that are inherent of being a small human. So you have any questions about kids? Cool. I have a lot of questions. Unconscious. So you're dispatched to a gas station bathroom for an unconscious person. So we can all guess where this is probably going. A 34-year-old male was found slumped against the wall with shallow, irregular respiration. So the bystanders saw him laying in the bathroom, or he was in the bathroom for about 20 minutes before anybody checked on him. So now he's cyanotic with pinpoint pupils and has drug paraphernalia. He's bradycardic, normotensive respiratory rate is 4, his SpO2 is 72%, sugar's normal. He has a faint pulse, but he doesn't respond to you. He's not breathing good at all. So this one, again, it's not a difficult vignette to figure out, but talking about differentials. So these are broad. So most likely with this guy, this is an opioid overdose, right? We also know that many times our opioid overdoses are not just opioid overdoses anymore. It's like ice, there's meth, there's whatever, cocaine mixed in with it. But the opiates seem to be winning in this situation. So even if there is meth on board, this guy has obviously been overtaken by the opiates. His respiratory rate is decreased, and now he's fixing to have a hypoxic respiratory arrest. But let's talk through some toxidromes and things of that nature. So we've got our opiates and sedatives. They typically look the same, right? So decreased respiratory rate, hypotension, less responsiveness, pinpoint pupils. You're not necessarily going to get that with benzodiazepines. Alcohol, not necessarily pinpoint pupils, but the pupils can kind of help you differentiate between kind of the sedatives on what you're dealing with. When you get into stimulants, so obviously that's going to be a person who's tachycardic, hypertensive, warm to the touch. They may have big blown pupils, right? Because you're activating your sympathetic nervous system. Your pupils dilate to help you see in more detail when you're in a fight or something. So you look at their pupils, they have big dish saucer pupils. They're hot to the touch. So this is probably more of like a stimulant type deal. with like PCPs, right? So you got tricyclic antidepressants, beta blockers, salicylates, and things of that nature. So those are where you start to get into more of the nuances of toxidromes. Carbon monoxide, cyanide, these can all present differently. Hypoglycemia, your strokes, your seizures and postictal states, POTS paralysis, head trauma, sepsis, hypoxia, hypercapnia. So there's a bunch of these different ways that these people can present with like this altered picture when you find someone down, right? So lots of things to consider. So your diagnosis. So this patient was obviously an opioid-associated respiratory failure. So what are you going to do for this guy? You're going to give him Narcan? Right? Okay. So what we have to do here is not necessarily to focus on the Narcan, right? You got to make sure this guy's ventilated. So putting in an NPA, an OPA, whatever, getting the guy ventilated, getting him back to a ventilated and normal oxygen state is going to be your priority here, right? A lot of folks, once they establish like a good airway, like an LMA or something like that, there are people who will consider doing Narcan at that time. Probably not the best idea, right? So if you go ahead and put in an LMA or you establish an airway and you're already decided that you're going to the hospital, maybe consider leaving it that way, right? Unless you want that guy in the back of your ambulance ripping his LMA out and fighting you. So in that case, once you stabilize his airway and you've got the guy's hypoxia and stuff like that fixed, you don't necessarily have to jump straight to Narcan. If the guy is, maybe still maintaining some form of a respiratory rate, this is somebody we can give Narcan to, watch for a second, he can go. That's a different story. Go ahead and pop that guy with Narcan and get on your way. But if a patient is in a near respiratory arrest and you're doing any kind of real big airway interventions, that's what your focus needs to be on in this situation, rather than popping him with the Narcan. So the key findings in this patient, he was unconscious, low respiratory rate, hypoxia, pinpoint pupils, all the things, right? So we suspected it, we got it, we did the things. So how does this work? I'm sure we all know the mechanism of naloxone. So your opiates are binding to your mu-opioid receptors, particularly in your CNS, and it decreases your respiratory rate, your central respiratory drive. So what Narcan does is it outcompetes your opiates. It kicks them off of the receptors. It sits on them but doesn't activate them. So you don't get all that euphoria. This is why people get pissed at you when they overdose and you give them Narcan, because the Narcan kicks all of the stuff off and you send them immediately into a withdrawal. So that's why those people are hot and bothered whenever they come out of it. Because it's not just happening where the respiratory centers are, it's happening everywhere. So you take everything away from them in immediate withdrawal. So that's why people get pissed. As we said, in the CNS, it decreases your central respiratory drive. So as such, it causes obvious hypoxia, kicks up your CO2, which leads to your decreased level of consciousness. All that CO2 buildup, all of that eventually leads to bradycardia and cardiac arrest. So again, just another schematic of kind of your mechanism of action, but easy enough, just goes in and out competes. So first point, ventilate the guy, as we said, right? So open his airways, suction him, BVM, OPA, NPAs, making sure we got him on SpO2, obviously, but making sure we've got good end-tidal CO2. Do your thing per protocol, but if you're not going to, just reassess his airway and ventilation, monitor your end-tidal CO2, and get him where he needs to be. So easy enough. So once you do that, so say you did give this guy Narcan, he thought we were in a good place to do it, right? So once he comes out of that, he starts freaking out. So now you've kicked all that opioids off and you've revealed his other underlying diagnosis, which was concomitant stimulant ingestion as well. So you can run through a whole bunch of different things with kind of your stimulant overdoses. As we said, the toxidrome is going to be everything up, right? So he's got big pupils, tachycardic, hypertensive, sweaty, temperature, all of that. You can go all the way into like chest pain, MI, seizures, stroke, obviously excited delirium. It's kind of your mixed or unknowns. You can kind of have a blend of that. We won't go too deep into all these, but you wind up seeing you can kind of see a mixed picture. So don't anchor on just one drug being kind of the point there. Wrong, give Narcan and see what happens. Right, ventilate the patient and decide whether or not Narcan is the right move is the gist of it, right? Anything there? Not much, not reinventing the wheel very much there, but just making sure we drive home ventilation.
So I think one thing here, Doc, that we see occasionally, not too often, is a lot of times medics get on the right track treating the airway issue. They intubate the patient, then make the realization that it's an opiate overdose, and then give Narcan. So is there any reason to ever give Narcan to an intubated patient?
No, and I hope I was communicating that. Yeah, if you've established an airway, no, that the ship has sailed, because now you're going to wind up with an awake guy that's tubed, right? So just like the LMA is going to be reaching for it, pulling it out, fighting you, pissed. Not a good situation.
On the opposite toxidrome, where you're talking about a stimulant overdose, like a cocaine overdose that you just talked about, we don't know what it is, but we see the toxidrome, right? The dilated pupils, the agitation, and all that. So we have this mystery. I always view it as a mystery of this kind of a umbrella of excited delirium that we currently generally give ketamine for. To me, for most of those patients, a benzo is a better choice. What are your thoughts on that? Ketamine versus benzo?
Benzo is the treatment for those. It is the most direct counter to all of that sympathetic stimulation that they have. Ketamine can, in those situations, put you in a kind of more precarious situation. If you're 100% sold that this is definitely meth, this is definitely cocaine, benzos are the way to go there, in my opinion.
Yeah, the issue with that is if you look at the state protocols, the dosing is probably a little bit low for the state protocols. So that's something we probably have to address at the state level. The other option is if you're getting your tail whooped by somebody that's done a lot of crack or meth or something, then maybe it's a little IM ketamine and then call med control to get orders reversed at that point. So that's the issue with the dosing of the benzos right now.
Yeah, and that's another thing too, is like ultimately with an agitated, stimulated patient, you have to protect yourself, right? So you've got to get control of the situation as quickly as you can. And if ketamine is what you need and what you have most ready access to, it's not the wrong answer. Sweet. It's a sick person. We'll run through this pretty quick. This is a 74-year-old female with weakness. Her daughter says she's been off all day, couldn't get out of her recliner. She's awake but confused. She's warm to the touch, flushed, breathing faster than expected. She doesn't have any chest pain. She just looks really fatigued. She's tachycardic, hypotensive. Respiratory rate is 28. Her SpO2 is 94%. She's febrile. Glucose is fairly normal for Alabama. Her daughter says that she was treated for UTI last week, so she's still on antibiotics. They don't seem to be working, right? So differential's not hard here, but let's focus on a differential for shock, right? So this is a setup for septic shock. But let's talk through the different kinds of shock, right? So we have distributive shock. So sepsis is going to be your most common form of distributive shock. And so what's happening with that is you're getting down the line, you're activating all of this inflammatory cascade, which we'll talk about shortly, but you're leaking fluid out into your third spaces. You're getting end organ dysfunction because of hypoperfusion. You're getting all these inflammatory markers, and you're getting, because of the malperfusion, you're getting more inflammatory cytokines, you're getting a lower pH. And so all this stuff starts to build on itself. But basically, this distributive type of shock is similar to like your anaphylaxis, to your neurogenic shock, to, I guess, medication overdoses from time to time. But what you're seeing is kind of a system-wide issue that's causing you to be hypotensive and malperfused. So you got your hypovolemics, right? So you got your GI bleeds, your dehydration, just typical. So you've got your penetrating trauma, blunt trauma, and then people from GI losses. Like you have a GI bug for a week or two and you poop all your bicarb and electrolytes and all that kind of stuff out. Same thing. You get an emptying of the tank, right? Cardiogenic shock. You got your MIs, heart failures, dysrhythmias, things of that nature. Your obstructive shock, so you've got a PE that you can't pump past. So your right heart can't get blood through your pulmonary arteries and back. So you're getting a backup there and getting hypotension because we don't have enough to pump forward. Got a tension pneumothorax, you've got increased intrathoracic pressure on your heart, so you can't pump out of that pressure. There's so much there that it's keeping it all inside. You've got a cardiac tamponade, so you've had blunt trauma. You'll see tamponades in like pericarditis, myocarditis. You'll see it in cancer patients. They get a malignant effusion. And so that is inside the heart. There's a big swelling of whether it's blood or fluid that compresses the heart and also prevents the pressure becomes higher than what the left ventricle can really fight against. And so you wound up with an obstructive shock from that standpoint. You just can't get it out. So weakness plus hypotension, that's your shock. Any signs of malperfusion, that's shock. That is a failure of the pump to pump forward and get oxygen to the places it needs to go, right? So this lady, suspected infection with hypotension, right? So she's had the UTI that's obviously failing outpatient treatment. What are you going to do about somebody like this? What was your first line typically for like a septic type shock? Give them fluids. Yeah, you can give them fluids. What if she has a known history of heart failure with an EF of like 15 or 20% and her legs are super swollen? She's run out of her Lasix. You can give her fluids? Yeah, it's probably fine. Leader's not going to hurt. Might be a person that you consider pressors early in, but ultimately, like, patient probably needs fluid regardless. So yeah, dysregulated host response, a lot of vasodilation, capillary leak, end organ dysfunction, including myocardial depression. So the pump's not working as well. You get all this dysfunction, this hypoxia, increasing acids or decreased pH, things aren't working as well, and you get in the vicious cycle, right? So this patient's in septic shock, and this is how that works, right? This is the fancy science version, but there's some words on there that are easy to understand. You get systemic inflammation, which is what sepsis is, right? Sepsis is like a blanket term for like a systemic inflammatory response, right? So you get your tissue and cell damage, you get all this vicious cycle. So that's just a picture of kind of what is going on there. So we've recognized infection, we've recognized the signs of malperfusion in this patient, and that they probably need a little bit of oxygen, that they need a little bit of fluid. So this patient, you give the fluids to them, you start running them, and they're still 70s over 40s. You're not really succeeding there. What are some thoughts that you go to from that standpoint? Like a push dose epi, levo, epi drip, dopamine drip, whatever you're doing, right? So this is a person, an older lady that's not maybe super responsive to fluids and doesn't look like someone who can stand a whole lot of it. This is a person that you might want to initiate pressors early, right? So people do get very nervous about a person with any signs of volume overload, us included in the emergency department, about giving these patients fluid. But in reality, if the patient has sepsis, which we're pretty convinced of in this case, you can still give some volume. You can still give a liter. There's actually this trial called the Clovers trial that investigated fluids versus early pressors. And in the subgroup that had CHF, CKD, or other reasons to have volume overload at the initiation of the 30 cc's per kg bolus. So if you're 100 kgs, that's 3 liters of fluids. There was not an increased rate of adverse outcomes from hypervolemia. So there's evidence out there that says that even in a person that's predisposed to this, you can give them fluids and be fine. That's not to say that there's not some sour, disgruntled ER doctor somewhere that's going to give you fits when you come in and they're getting fluids. And they're like, why are you giving this person fluids? You can just say that, they need some fluids. There's evidence out there that this isn't hurting them. So you're not wrong for that. But you are right for considering early pressors in these situations. You can really help some people out by initiating that from the jump. So have a low threshold to begin pressors in these folks, but know that you're not going to kill this person by giving them a liter.
So Doc, would you say it's fair? Because we're going to try to, from a paramedic's point of view, we're going to be trying to differentiate between the septic patient we need to give fluids to and the septic patient we're going to withhold fluids. So to me, it's two different patients. One's that has the indications like a history of CHF, swollen legs, evidence of right heart failure. And then there's the one who has wet lung sounds with all the above. So sepsis with wet lung sounds, would you withhold fluid from that patient?
Or, I mean, I guess if they're
And desatting.
Yeah, if that's the case and they're hypotensive, I think I would start a little bit of fluid there. Like I said, if they can get some pulmonary edema and things like that, just the same from like all of this end organ dysfunction and leaky capillaries. So I would be hard pressed to not give them anything unless there was, and I'm trying to think of a situation where I would give them no fluids. And off the top of my head, I can't really think of one. I think unless you're going to be dealing with this patient for a prolonged period of time, I think the amount of fluid that can get into this person by the time you get to the hospital may help and is not going to hurt. And so even if, unless I was convinced, unless I thought that the primary issue for this patient's presentation was volume, and then there's a question of infection, then yeah, I would probably go more down the volume pathway than I would the sepsis one. But if this is like overt, like this is an infection and the patient is showing signs of shock, I would give the fluids.
Yeah, so really with the wet lung sounds coupled with signs and symptoms of possibly septic shock or sepsis, would you say that blood pressure is a big decision maker there?
Yeah.
In other words, if they're normotensive or a little hypertensive, probably less fluid. If they're hypotensive, then probably try some fluid.
Right. Yeah. Yeah. I'm talking kind of from a perspective of shock. Cool. I like that. It's good. Chest pain. 59-year-old male, indigestion, pale, diaphoretic. What time are we at? We're at 54, so we'll start rolling pretty quick. So this is a chest pain patient that is not well, but you get a 12 lead, and the 12 lead is without a STEMI, right? So now what are you thinking? So you have a patient who has classic symptoms, has crushing chest pain, but has no STEMI. Vital signs, bradycardic, borderline hypotensive, his respiratory rate is normal, his SpO2 is kind of normal, but he's got no clear ST elevations, but he looks like a heart attack. Do what? Yeah, exactly. There's plenty of things that this could be, but he looks like a duck and sounds like a duck, but his EKG doesn't say it. But that doesn't mean that there's not something else going on, right? He could be having an NSTEMI, which is a very common presentation of myocardial infarction, which is technically a heart attack. It's not a STEMI. It's not like cath lab right away, but this person could be having acute coronary syndrome without the STEMI, right? But other things to think about in a patient like this. Think about dissections. Again, we think about PEs. We always think about PEs in emergency medicine. We think about cardiogenic shock. We think about heart failure exacerbations, pericarditis, a lot of things to kind of start running through, right? Pneumothorax, pleurisy, just regular old musculoskeletal pain. We can get referred pain from pancreatitis, from your gallbladder. So there's a number of things that this could be, right? So diaphoresis, nausea, jaw radiation, hypotensive bradycardia are all these things that point us towards acute coronary syndrome. Diabetes, obesity, old age, the textbook of the old female, right, is the one that presents with gastrointestinal type symptoms. So there's atypical presentations for this as well that you have to be kind of on the lookout for. But the trap here, kind of in this case, is letting a non-diagnostic first EKG make you just write this off as something else, right? So this guy is going to wind up with an NSTEMI, right? So he has ACS. You've got it from like a plaque rupture or erosion is going to give you your classic STEMI, right? So the plaque ruptures, you start to form a clot on top of it. You clot off a coronary artery, and that's that. But There are plenty of others ways that you get myocardial infarctions, right? So your type 1 is your classic STEMI. So you get the eruption, you get the clot, you have a STEMI. It shows up on your EKG, you go to the cath lab and get stented. There are other ways that these infarctions kind of present, right? So you get this slow buildup of atherosclerosis, and you get these critical occlusions, but you still are perfusing a bit. And so you'll wind up seeing maybe some EKG changes, but you'll start to see people's troponins rise in the emergency department, and in their hospital stay, they wind up getting cath, and they find like a 95% occlusion or something along those lines. A lot of folks will vasospasm into these STEMIs or into end STEMIs. So your cocaines, your people who are, for whatever reason, sympathetically stimulated, you'll get a coronary vasospasm. They have all these presenting symptoms, and then they relieve. People have dissections into coronary arteries that cause full-fledged STEMIs that behave in the same way. And then you get demand ischemia. That's going to be one of your more common causes of like your end STEMI, and we call that a type 2. So that's a patient with sepsis. That's a patient with AFib RVR, some kind of serious cardiac strain that causes ischemia or subendocardial ischemia, but not enough to have like a full-fledged wall thickness and STEMI, right? There's a couple of things that we have to look out for as far as STEMI equivalence and then critical coronary occlusions. So you have things like your Wellens syndrome, which are somewhat rare, but down in V2 and V3, a lot of times you'll see this biphasic T wave. That's not super common, but they are seen. And then most of the time, a Wellens will present with this like deeply inverted T wave. You can also see that interestingly in traumatic brain injury. But these are kind of your STEMI equivalents, and then your critical ischemia that you want to be on the lookout for as well. And that slide is really a whole lecture in itself. Just some things to be thinking of. So your strategies, you want to get an EKG as early as possible, right? When the clinical situation fits, get the EKG. Repeat the EKG if your symptoms change. So if the patient has cardiac type symptoms and you get your first EKG and there's nothing to it, don't be afraid to repeat that with some frequency while you've got them. So just be sure that you're on top of it. You're not afraid to reprint EKGs if things change, or if you're more suspicious for kind of progressive symptoms. Just because they don't have a STEMI on the EKG doesn't mean that something's not going on. So if your index of suspicion is high enough, make sure that you're doing the right things and taking them to the right places, right? We've got a confused patient. I don't think we're going to be able to get through these. We're right at 10 o'clock, but got a few more cases on here. We can talk about them if you want to. There's trauma, hemorrhagic shock, and things of that nature, but I think we're out of time. So if y'all have any questions about anything in particular, we can run through them, but.
Okay, no, I think it was very good. I appreciate it. Good work. Any questions in the room?
Yeah, thank you, Dr. Sullivan. That was really good. So we covered a lot of ground there.
Yeah.
Definitely look forward to maybe a lecture down the road on some of those more specific EKG findings like D. Winter and Wellens and all that stuff that some of us older guys are still trying to get our head wrapped around.
Me too.
Yeah, we really appreciate that. So everybody, we really appreciate you joining us for EMS Challenge today. If you're watching online, we're going to take a 5 or so minute break, let everybody stretch your legs, and then we're going to come back with a lecture on burns from Dr. Holland. So see you in a few minutes. Everybody, welcome back. We're glad to have Dr. Holland with us today from UAB, and he's going to be talking to us about burns. So welcome, Dr. Holland.
Thank you. So my name is Wes Holland. I'm a second-year resident at UAB. And this is a very broad topic of burns, so we'll try to touch on a little bit of everything, maybe have a couple slides on the cyano kit, carbon monoxide poisoning at the end. But here are our objectives. So first, we'll just classify the burns by depth and the total body surface area. Like I said, we'll talk a little bit about inhalation injury toward the end. We'll talk about a burn-specific primary survey that we would do in the ED, and kind of talk about how the care continues after you bring them to us at UAB or another burn center. Talk about a little bit about the resuscitation, and we will also talk about the pre-hospital priorities that are specific to you guys. So, in terms of epidemiology, burns represent a decent morbidity and mortality. There's about 500,000 burn injuries per year. You can see most of them are flame or fire or scald injuries, particularly scalds in the younger kids. And then the high-risk groups you can see on the right, kids, they're prone to getting into stuff, scald injuries. Elderly, they just have really thin skin, and when they do get burned pretty bad, their mortality is a lot higher compared to a younger patient with the same depth and total body surface area burns. So to kind of talk about classifying the burns in terms of first degree, second degree, third degree, and so on, we need to understand the skin layers. So at the very top, we have the epidermis, and then below that, there's the dermis, which we can split into 2 layers. The papillary dermis is on top, and the reticular dermis is right underneath that. And the reticular dermis is where the hair follicles are, where the sweat glands are, some more of the functional parts of your skin. Then below that, you have the subcutaneous fat. Then even deeper than that, you have the fascia and the muscle and then the bone. And each degree of burn involves another layer. So it would be nice and simple if everything was still first degree, second degree, third degree, but that was too simple. So we broke second degree into 2. So that's now superficial first degree, superficial partial second degree, and then deep partial, which is another type of second degree. And then we have third degree, which is full thickness. That stays the same. And fourth degree is just the really charred burns that we'll get into in a second. And we'll kind of go through all these different characteristics one by one. So this is a first degree injury. It's just red. Only the epidermis. It doesn't involve anything deeper. No blisters. It should be pretty dry. It shouldn't be weepy at all. It should blanch with pressure. It's just like a sunburn. Painful for sure, because none of the nerve endings are damaged, because again, we're just superficial in the epidermis. And importantly, when we're calculating the total body surface area, and you're calling that in, these do not count toward that. So we're only counting second, third, and fourth degree burns toward the total body surface area. So this is the first kind of second degree, superficial partial thickness. So this is where we have the epidermis and that first layer of the dermis, the papillary dermis. These are typically moist. They can be weepy, and these are the ones I usually think about having intact blisters. They are extremely painful because, again, we're not quite deep enough for the nerves to be damaged. And it takes a little bit longer to heal. So these will take like 2 or 3 weeks to heal. We'll talk about management a little bit later. Some places debride these, some places don't because they're intact. This is the more serious kind of second degree. So this is deep partial thickness. You can see this probably was blistered, but now the blisters are gone and it's burned a little bit deeper than that. So we're talking about epidermis in both layers of the dermis now. So this is a pretty significant injury. Sometimes it can be a little pale. Sometimes it's red like this and a little bit mottled. Again, I always think of like ruptured blisters. Like it looks like there was a blister there at some point, but either it got burned through that or it's just not there anymore. The blanching can be a little less significant, so you don't see as much of that. And sometimes people can have reduced pain, but from what I've seen, these are still really painful, probably because they're at least surrounded by more intact skin layers nearby that are also really painful. And it's hard for patients to kind of distinguish between like the border of this burn and then the corresponding burn right beside it that's a little bit worse. These take a lot longer to heal. So these can take like 3 to 8 weeks. Sometimes they need a graft. Sometimes they don't, but that's not really, I don't determine that. That's up to the burn surgeon ultimately. And an important thing to know is that how the burn looks initially isn't how it's going to ultimately look 2 to 3 days from now, because they are dynamic, and what tissue is lost initially might not be all that's going to be lost, because you might have further tissue lost and kind of expansion of the injured area over the next couple of days. So this is 3rd degree. These are the ones that are white, they're leathery, they're kind of tough. It's just like really rough skin. And here, again, we are through the dermis. So the entire dermis is involved. Usually, I wouldn't say they're painless. They can be painless because the nerve endings are damaged. But again, like before, you can see here, the middle is 3rd degree. It's white, it's leathery, but then you have some more 2nd degree and maybe a little bit of 1st degree at the very edge. So it seems kind of rare to have just one kind of burn. They all are kind of together. Sometimes the worst is in the middle, and then as it spreads out, it gets less severe. These will not heal. These will definitely need a graft. But again, that's something they can determine a few days from when they get admitted. These are also important because when they scar like this, or when you have that really leathery skin, if it's circumferential around like a digit, around your arm, around your neck, it kind of can constrict the blood flow. And we'll get into that a little bit, but that can be an issue because you're not perfusing anything distal to that burn now, and that can cause a lot of big problems. So 4th degree, these are pretty easy to tell. They're black, they're charred. Like sometimes you can just see the muscle striations because you're now burned down into the muscle. These should be, like the 4th degree itself should be painless. Again, you may have surrounding areas that are painful, but this should be painless because you just completely burned the nerves. These will require multiple grafting surgeries. They'll be admitted to, the burn ICU for a long, long time. And, for burns like this big, a lot of people just don't make it. They end up getting admitted. They get secondary infections. They have all these other kind of problems. They're really nasty injuries, and it's kind of sad to see them just sit up there for months and just kind of waste away. So this is a quick rule. It's important to estimate the total body surface area. Remember, we're not including the 1st degree burns, so only the 2 types of 2nd degree, 3rd and 4th. This applies mostly to adults because the kids, their head is proportionally larger, and we can adjust for that. I think we'll get into that later in the lecture. So the head for the neck, all head, front, back, each side should be 9. And this is the rule of 9s because we can kind of break everything up into 9s. Each arm's a 9%, front and back. The front side of the chest and abdomen is 18, so that's 9 times 2. The back is 18, again, 9 times 2. The genitalia, that's 1%. It doesn't really fit, but it's pretty easy to remember. And then each leg is also 18% circumferentially. So if it's just the front of the leg, but it's the entire front of the leg, it's about 9%. It's really quick. It's fairly easy. It can give you a rough idea of where you may need to take a patient. Yeah, here's another chart showing basically the same thing. At the bottom, it shows how you can adjust it for younger kids. So the head is 18%, I think, in newborn babies, because each half of the head is 9.5% for that 0 years of age. So you can see that it's not the same proportions. After like 5 years old or so, it's pretty similar to adults, and you can roughly use that same estimate. Broadly categorizing the burns in terms of burn severity. Before we move on to this, any questions? That was a lot of background. No? Okay. So if we try to break these into minor, moderate, and major, minor is just in general less surface area, not as deep. We think about the major ones is just deeper, more body area. We don't have to get into fine details of this, but I would like to talk about the burn center criteria because this will affect kind of where you're going to take a patient. So first one is any partial thickness burns greater than 10%. And I feel like 10%, it looks a lot bigger than it looks bigger than 10%. Because we have people calling from the field, it's like, oh, it's 30%, and it turns out to be like 11%. So 10% is like actually pretty serious. It seems like a small number, but in reality, when you're looking at it in person, it's pretty big. Full thickness burns of any size, so any third-degree burns of any size, even if it's just a small area, they still need a burn center transfer because they very well may need a skin graft. Chemical burns, those are a little trickier, so they also need to go to a burn center. We won't get into the specific types of chemicals that can be a real issue. But just important to know that those are a special category. Burns with pre-existing conditions, old people, people who have a lot of comorbidities, people who already have circulation problems like heart failure or vascular disease. They're going to have an even harder time perfusing the remaining tissue and any kind of skin graft that they get. So they're just predisposed to complications. So they'll need a burn center as well. Children, where the burn center or whatever hospital can't take care of pediatrics, so they'll need to go to children's or another pediatric hospital. That one's pretty straightforward. Another one is burns, face, hand, feet, genitalia. Those are kind of easy to forget if someone just touched a hot stove and it's a burn on the palm of her hand. But because it goes over really small joints, hands are really important. They are important to determine our function. Those probably should go to a burn center just to get evaluated and make sure there's nothing in addition that needs to be done. Also because the digits are pretty small, you can easily get circumferential burns around your fingers, and to a lesser extent your toes. And again, like we talked about before, we can run into problems when you have bad circumferential burns.
So I think TCC can help in the BRIMS region with this decision and statewide. Is that right, Dr. Friedman?
Yeah, statewide. So TCC is a great resource of where to go. Burn trauma management is complicated. UAB does it.
Yeah.
There are a few other places in the area, but they're true full service burn centers are hard to find.
Yeah.
And these are devastating injuries when you start talking about full thickness burns of that nature, or places like he's talking about the important parts, right? Hands, feet, face, privates, those things that get burned really need a specialist. And it's a long, long road to recovery on a good day for those folks. So, yeah.
Yeah, so hopefully TCC will help, but here's a little background just so you kind of know what they are thinking. Trauma and burns, then inhalation injury, importantly, which we'll talk about a little bit later. Anything that's affecting their airway, that's more concerning, probably needs to go to a higher level center. So pre-hospital care, let's actually go into the treatment and care of patients now that we kind of talked about the background and burn severity and all that. So this is a lot of words, but basically pre-hospital management, make sure the scene is safe. There's still a burning fire. And if there is, a lot of y'all I think are firefighters, and you can tell me about that. Importantly, don't remove any clothing that is like burned into the skin. Some kind of this synthetic polyester stuff can get stuck. Just leave it be, and we'll take care of it once they get to the hospital. Probably the most important thing on here is the field airway screen. So you're going to look for facial burns, any singed nose hairs, soot around the mouth, soot in the back of the airway. If they are having any carbonaceous sputum, like they just have a cough and they're having some black gray sputum, that's concerning. I'm not saying you need to, take their airway on the scene, but just something to pay very close attention to and to, make sure you tell whoever's taking report at whatever hospital they go to. Cool the wound for less serious burns, and you don't need to transport them immediately. You can have them run their hand or their arm under a faucet. It cools the burn. It usually provides some pain relief, and we're actually pretty bad about doing that in the hospital, I feel like. But don't use ice because that actually can cause more damage. For fluids, again, like any resuscitation or serious resuscitation, get 2 IVs. Try to get it in the not burned skin. But if it's a terrible burn and you have no choice, you got to do what you got to do. You don't have to load them with liters and liters of fluid. You probably won't hurt them if you do, kind of like what Dr. Sullivan was saying with heart failure. But you can start, just let a leader hang on the way. These people will need lots and lots of fluids, as we'll talk about. So giving them a leader, even if it's, a frail old person, they're going to need it if it's a large burn, like greater than 20%. And then wound coverage, don't just put a bunch of wet gauze on a 40% area burn, because they're going to get cold very quick because they have no skin barrier at this point to help them with their thermoregulation. And pain meds, these are super painful. You guys carry fentanyl, ketamine, they work well for this. Any questions? All right. So when they get to the ED, this is kind of what we're going to look at. We talk about the A, B, C, Ds, and Es. This is a little bit more detailed than we probably do initially, but just gives us something to talk off of. So airway, if there is an immediate airway concern, they have stridor, they have soot in their mouth, they're not ventilating well, then we're probably going to take their airway, because we might not have that chance later if it gets any more edematous or obstructed in another way. That could be a nightmare later. So it's better to intubate early. And then for breathing, so we'll touch on it a little bit later too with carbon monoxide poisoning, but the pulse ox can mislead you, because it could say 99% in carbon monoxide poisoning, because it can't distinguish between oxygen bound to hemoglobin and carbon monoxide bound to hemoglobin. It registers them as the same thing. So just to be aware of that. We're pretty liberal with oxygen for these victims. And one thing to think about, I talked about circumferential burns. If you have circumferential burns of your chest, it can actually kind of constrict your breathing, which can be a huge problem. And we'll kind of get into how that is managed in a bit as well. That's just something to be aware of. It can really restrict your ventilation. For circulation, these people need lots of fluids. We'll get into that calculation in a second. Since they have no skin barrier, they have lots of losses through their skin through evaporation. They can't hold fluid in them, so they need like surprising amounts of fluid. We'll get into more of that in a second. For disability, we talk about carbon monoxide, cyanide poisoning, and we'll talk about how to treat that, but that can affect their mental status for sure. And exposure, it's really important that we do it. We talked about the rule of nines. In the field, if you can, it's really helpful to have an estimate, I think, when the patient's coming in, to kind of get ready for them and to anticipate what we need to do immediately. In the ED, we'll check for pulses distal to any circumferential burns to make sure that those extremities are getting good blood flow. And then we'll keep them warm. So kind of the same idea as not just putting a bunch of wet gauze on a big burn. We're going to give them warm blankets, even warmed fluids, because they really can't hold in heat with these big burns. All right. So this is after y'all hand off to us, but this is kind of what we use to guide our fluid resuscitation in the first 24 hours, the Parkland formula. So basically, you take their weight in kilograms, multiply it by the total body surface area, to multiply it by 4, and that's the total number of milliliters of LR they'll need over the first 24 hours. So you divide that number by 2, and you give that half in the first 8 hours. So this example down here for 70 kilogram adult, so it'd be 70 times 40 times 4, and that's 11.2 liters, that's just a lot of fluid for anybody, but that's how much they need, and sometimes they'll need more or less, depending how they respond to that initial fluid. But so you have that, you divide it by 2, the 11.2 liters, you get 5.6. They need that in the first 8 hours, some of which may be given by y'all in the field or on the way to us. So just important to keep track of that, so you can tell us and we can include that in the calculation and not over resuscitate them. Once they get up to the burn ICU, a lot of the fluid resuscitation is guided by their urine output. So every hour the nurse will go in and see how much urine they produced. They get a Foley so we can track it really closely. And the goal is like a 0.5 milliliter to 1 milliliter per kg per hour. And we can adjust the rate of the fluid depending on that. All right.
Hey, I'm gonna say a couple things about fluid management. So he made a great point. This is the way we calculate it in the hospital. Okay, so it's really tough to calculate this fluid in the pre-hospital or inter-facility world. There's the Parkland formula. There's another one out there. There's some new modified Parkland formulas that say you give the half of that fluid over the first 8 hours, and they kind of readjust it with some new literature. Said no, actually, you don't do that. You give it over 24 hours. The actual fact is we don't know the exact amount. So what we kind of do is we trend labs and urine output in the hospital, which you guys can't do. So my thoughts on fluid resuscitation is they obviously, if they're burned, they need IV access for fluid resuscitation. And it's almost like a crush injury. You get all this jacked up tissue that releases things. You get third spacing of fluids. You can get increased potassium levels, things of that nature. So it's really kind of looking at that patient. You know, you got this guy with the burn that's over his chest and one arm. So maybe that's 9 plus 9, 18%. Whether it's 10% or 18%, it doesn't matter. You're going to give them a first bolus of about 20 cc's per kilo if they're a kid. If they're an adult, they're probably going to get about a liter, okay? If you're moving a long distance to a hospital, you're just going to kind of follow the vital signs. If they're still tachycardic, they're hypotensive, they get more fluids. If they're gurgly, right, they don't get as many fluids. It sounds almost kind of redneck in a way, but that's the way you're going to manage it clinically. If you're doing inter-facility care, the things that you can look for is you can look at that urine output that they have, not the number, but look at the urine itself. If the urine's coming out and it's dark and it's red, they need more fluid from you guys. If it's nice and clear, you're probably fine keeping your fluids to keep open. Does that make sense? When you think about electrolyte changes, I know I talk a lot about hyperkalemia. You'll actually see that in burn patients sometimes. They get hyperkalemic if we don't start treating that. So you can watch them. If they're tachycardic and now their QRS starts getting wide, right, and they're burned, you got to think, okay, I got third spacing of fluids, their volume down, they need more fluids, and I got all kind of cells that are damaged, so potassium's going up. So now they probably need some calcium and some bicarb, almost like a hyperkalemic patient or a crush injury patient, or maybe even some albuterol nebbed on these folks. So it's what the patient looks like. It's not just the math, if that makes sense. Maybe so, maybe not. Good. All right. Thank you for kind of good smiling. Thank you, though. It was coming. Yeah. Yeah. Great. All right.
Yeah, and good point about the hyperkalemia and like kind of like a crush injury, especially as we'll talk about later with like burn injuries or electrical burn injuries or lightning strikes. It just causes a ton of muscle damage.
Yeah.
And all of those muscle proteins are released, and they're terrible for your kidneys. It can cause some real damage. And the way to fix that is just flush it out as safely and as fast as we can. So we're going to talk about debridement. Some of this is done in the ED, some of it's done in the OR. I don't do a lot of this. Our nurses are great and do a lot of the soft, non-sharp debridement in the ED. I don't really do any sharp debridement. I guess if you were somewhere alone, like kind of out in the middle of nowhere, and you absolutely had to, we could. But this is just cool to know about. So we're not going to get into a lot of details, but important thing is pain control. Seems like it's excruciatingly painful because what we're doing is just kind of getting gauze, putting an antiseptic solution on it, or even just sterile water, and just kind of scrubbing the wound, especially the edges, because we're trying to remove all that loose tissue from like a ruptured blister, because that can get infected really easily. Even for intact blisters, at UAB, we de-roof those. So we'll essentially pop the blister and then kind of tear back the margins. So there's no flaps. That's the opposite of what we want. We want to get it nice and clean, smooth edges. So there's no rough borders or anywhere that can trap infections. So it's super, super painful. Ketamine works really well. We give people like decent doses of Dilaudid too. Just whatever it takes to let them tolerate it. So for eschars, we'll talk about a little in a second. That's kind of like the third degree burn when it gets really hard. and can constrict blood flow, restrict your breathing, and other things. Sharp debridement, that's typically done in the OR. And then antibiotics, I feel like every institution has a different theory about this. So I was trying to look up what is the standard, and it doesn't seem like there is a standard. So at UAB, I know we do a lot of zero form and then cover it with gauze. It's just a non-stick dressing with a little bit of antibacterial activity, and it lets us take off the cover or the dressing without completely tearing up the surface of the wound again. But again, every institution is different.
Hey, Doc, do you see a role for pre-hospital antibiotics for serious burn cases?
Yeah, I really don't. Obviously, if the wounds are super contaminated, you have a long transport time, there's issues with extrication, then it's a reasonable thought to do. But you're only really carrying Rocephin and Ancef. So, maybe not. Not a lot of wound care we're going to do in the field except just, control bleeding issues, cool them off a little bit if they have warm clothing or still charged stuff on them. You're not going to do any debriding in the field.
No.
And if I was working in a non-trauma center, like you said, I'm not going to debride these things. It takes a real specialist to recognize what's going on. If I start scrubbing or debriding a burn injury like this, there may be a few places in that full thickness burn that still has not full thickness, and I don't want to tear up whatever good skin may be left. That needs to be done, left for the surgeon to figure out how they're going to do this and manage that. So these are horrific injuries. If they're burned and not hurting and not uncomfortable, you should be very concerned. That means it's full thickness. It's a really bad day for them. Unfortunately, if they're burned and they're uncomfortable, that's a better sign for long-term outcome, but it's got to hurt, right? So I would be very liberal or aggressive with pain management as long as you're watching your airway, because these things hurt.
Yeah. Here's just kind of some pictures of the non-sharp, I guess, the blunt debriding. You just see someone has some gauze, is kind of trying to almost tear the wound margins to try to get that dead non-viable tissue away. And then you can see the blister. They just de-roofed it. They took the actual blister off because, if it's intact, it's sterile inside, but who knows how long it's going to be intact. If there's some kind of breach of that sterile barrier, it can easily get infected, and then again that just complicates the whole course of things. Yeah.
What's interesting is I've learned from experience, because I burned the crap out of my own hand. But most of the patients that have hand burns, the reason you want them to be referred to a trauma center is because burns like that right there, it might appear to be healing okay, but it'll actually contract on top of that knuckle. And so they need to have close follow-up. One, so if they start contracting, they won't be able to close this finger, and they'll actually have to go to like physical therapy. And so I burned the crap out of my knuckle, and you just have to keep busting open that scar tissue till it heals to where you can close it. So that's why even burns that small need to be going to like a trauma burn center.
Yeah, it definitely sounds like overkill, but it's okay. Everyone will understand why you bring them to a burn center. That's where they need to be.
I would add to that too, that especially for the firefighter paramedics in the room, oftentimes we see thermal burns right after they happen, and a real serious burn can actually be completely unimpressive right after it happens. And so realize it's going to get a lot worse over the next few hours. I've seen a lot of patients on the scene kind of held, oh, it's not that bad, we'll send you to occupational health tomorrow. And then, an hour later, yeah, you got to go to the burn center yesterday. This is a lot worse than it was an hour ago. So just realize it's going to look a lot worse in a couple of hours.
Yeah, I think something that's coming in the future is going to be beneficial is more telemedicine type things where we have a number that EMS can call and, hey, I got this guy with this burn. Do they need to go to a, hand burn center tonight? where you can snap a picture and send it to us and we can look at it and say, oh yeah, that definitely needs evaluation tonight, or no, that can be seen tomorrow for those things. And we're trying to work on processes like that to make it more efficient. With the technology that we have, we can do those things now. We just got to make it more into the system. So.
Yeah. Yeah, and the burn's getting worse. I think I briefly touched on that earlier, but even when we're all looking at the same patient at the same time, like I'll stage the burn is one thing, the surgery resident will say it's another, and then the burn surgeon will disagree with both of us and say it's this third option. So there's a lot of subjectivity, and it can be frustrating. And then, you know, how they evolve over time complicates that even more. So basically, they're just nasty injuries. We won't get into the topical antibiotics. We don't need to worry about that. So we talk about those eschars, like the bad third degree full thickness burns that can kind of constrict an extremity or a digit or your chest. What we're worried about is them causing compartment syndrome, which we'll talk about on the next slide. And the way to fix that is to cut the eschar open to allow for blood flow. So you can see here, if in these diagrams, these are kind of the lines they would take. Like if they burn the entire front of their body, they would get an incision down their arm, probably on both sides, and then kind of this box around their chest, which will let the chest expand so we can actually ventilate the patient. And some signs that we need to do that would be, see down here, circumferential chest burns. Like if their peak pressures on the vent are really, really high, we're getting lower tidal volumes, any other sign that, you know, they're not ventilating very well, then that could be an indication to do it. If you can't see their chest rise in the field, that could be an indication, although we won't be doing this in the field, and I don't do this either. They do this in the OR. Talking about the extremities, like their fingers or their arms that have circumferential third degree burns, we can see if they have a pulse. Other signs of compartment syndrome, you can have paresthesias, you can have pain, you can have pallor, like it's kind of pale, and then the worst is pulselessness, and that's like a hard indication for one of these escharotomies. And then this looks pretty gnarly, but that's like what it can look like. So they kind of just make cuts where things need to move, and then it now moves. And chances are they'd probably have to have all that grafted anyway. So, yeah, they're not good injuries at all.
Do you do anything different for?
They probably just go around. Yeah. Yeah. We can just talk about this real quick. Special populations, we talked about at the beginning. Kids are different. They're disproportionate compared to adults. An important thing with fluid resuscitation for them, at least once they get to the hospital, is you need to add a little bit of dextrose, a little sugar for them. And you have to consider always non-accidental trauma, even if something looks as like a really good story and it looks like it could have happened that way. You got to consider, like, is the child old enough to actually do that? Does the story make sense, you know, with their developmental milestones? Do they have a weird pattern of the burn, and so on? So that's just something to be aware of, and y'all kind of get a first look at the scene, so you can kind of maybe get some early clues that could be the case. Geriatric patients do a lot worse. They're just more fragile. Their skin is frail. We know it tears really easy. It also doesn't do so well with burns. They have a lot more comorbidities. They may already have underlying kidney problems, and then they get a bad burn injury. Their potassium goes up. Their muscle proteins leak out into their blood and further complicate that kidney disease. People can end up on dialysis in the ICU from all this, not uncommonly. And then pregnancy, just the degree of the burn correlates with the fetal mortality, which is pretty obvious, it seems like. fetal mortality is really high in greater than 50% burns. And even the mom's mortality in greater than 50% burns is decently high. We talked a little bit about these already. So early complications are hypovolemic shock. You kind of get this burn shock because, you know, the third spacing, the distributive type shock where the fluid goes where it's not supposed to be, out of the vessels, into the tissues. You have airway compromise, whether that's through a circumferential burn around the neck or just airway swelling from an inhalation injury. You get respiratory failure. Because of the high potassium and the hyperkalemia, you can get cardiac arrhythmia. Ferguson talked about that a tiny bit and how you can treat that with calcium, albuterol, bicarb, so on. Then hypothermia, which we touched on as well. These people get cold really fast. We have to keep a close eye on their temperature. Subacute, a few days to a weeks later, probably most common is like sepsis and infection. We see that a lot up in the ICU. It seems like everyone with really bad burns who undergoes a lot of skin grafting, like inevitably gets septic at some point and ends up on pressors, which is like the worst thing for them because they're vasoconstrictors, and that even further prevents perfusion to their new skin grafts, and then the skin grafts fail and they have to start all over again. So it gets really messy. And then late chronic findings, you get those contractures like Kirby was talking about over joints. The scar tissue is just really tight, kind of limits your range of motion. Okay, any questions before we move on to a slightly different topic? Okay, so spend a little bit of time on both of these things, but it'll be pretty quick. So carbon monoxide, so we talked about it binds hemoglobin much stronger than oxygen binds hemoglobin. So it almost like kicks the oxygen off the hemoglobin. This prevents oxygen from getting delivered to the tissues because most of the oxygen is delivered to the tissues with hemoglobin, not just the oxygen dissolved in the blood, which probably isn't affected very much with this. It also binds some muscle proteins, can cause some cardiac problems, some other muscle problems. And importantly, like we talked about, it can't be distinguished on pulse ox whether they have carbon monoxide poisoning or not. So it's just something you have to kind of keep in the back of your head. Look at the symptoms. In this chart down here, it shows the common symptoms like headaches, usually the first, and then it progresses. Eventually get altered mental status. You can even get seizures and a coma. But compared to cyanide poisoning, this is typically a lot slower, and you can kind of watch the symptoms develop rather than cyanide. We'll talk about they crash real quick. What we can do for those, or before they get to the hospital, you can just put them on like a non-rebreather, try to wash it out of them, basically. I haven't seen it, but sometimes you could hypothetically get them on hyperbaric oxygen if it's really severe, but they'll need monitoring after that, and admission to the hospital if it's really bad. So cyanide. So I learned a few things when I was looking over all this, and it's pretty interesting and how well the cyano kits really work for this and turn people around like Narcan. So burning synthetic materials, like burning plastics, is like how I think about it. So any kind of house fire, like garbage fire, not really associated with, wood furnaces or, heaters or lamps and stuff like that. In the winter, it's more like actual like combustion of plastic. So it binds to something in your mitochondria called cytochrome C oxidase. It's not important. It just decreases your ability your cells to make energy. And that causes a huge issue. You get this giant lactic acidosis, which we'll see on their lab workup, that just doesn't clear despite all the fluid we're giving them. And probably the biggest thing to watch out for is just the symptoms, because they'll show this before they even get to us. They just get really altered, lose consciousness. They get bradycardic. They have just refractory shock. It's kind of like falling off the cliff. And if you have that in association with a house fire or other burning plastic of any kind, I would just give the cyano kit, because it very well could be cyanide toxicity. And it's a clinical diagnosis. We don't really need labs to confirm this. because by the time the labs come back, it'd be too late. We'll touch on electrical injuries. There's different types. You can touch something. It could be a high voltage injury. It could be a thermal injury, like a burn type injury from the electricity. Most important thing to think about with these is cardiac, just because, we defibrillate patients to get their heart back in rhythm. This can definitely get them out of rhythm. Can cause rhabdomyolysis, which is just muscle breakdown. And again, that can lead to kidney problems, can lead to hyperkalemia, can lead to arrhythmias, which ties back into the cardiac stuff. Just quick compare and contrast lightning versus a high voltage injury. So lightning's direct currents, DC, rather than the typical AC that we get with like wall sockets. And the lightning is extremely brief, although it's like incredibly powerful. So like 100 million volts compared to maybe 1,000 volts from a wall outlet. But it's super brief. So sometimes their injuries could surprisingly be not even as severe as like a bad high voltage injury, like at a workplace or a factory or something. Lightning tends to push you into asystole, whereas high voltage tends to give you VFib. It's just standard ACLS at that point, but they really respond well to early CPR and defibrillation, because it's usually an otherwise healthy person with like a normal heart, normal everything else. Their rhythm just got reset in the wrong way, and you just need to reset it. So it's a good cases for prolonged resuscitation. If it's a young, healthy person who was found down and CPR was started pretty quickly by bystanders, like hopefully they'll have a good outcome and you can get them back pretty easily. So that kind of goes into triage priorities. So if you get to a scene where lightning struck, there's a bunch of people on the ground, maybe some are crawling, some are talking. Instead of going to the ones that look like they're more okay and just, leaving the dead ones as like expectant or tagging them with black, you will go to them first in this case, because like we talked about, they respond really, really well to early intervention. And if someone's already, crawling around, talking, doing something, they're probably going to be okay anyway. So here we go to the most severe first. Put the pads on them, do CPR, ACLS. Hopefully we'll get them back.
Hey, Doc, being involved with some wilderness medicine stuff over the years, I know a lot of the literature suggests that lightning strike victims in cardiac arrest, it's often a hypoxic arrest. It's a totally hypoxic arrest. The lightning actually kind of stops the inherent autonomic respiratory drive. And so that's kind of what the justification is for the reverse triage, is that if you can reverse the hypoxia, they usually make a full recovery. But that period of hypoxia can vary depending on patient. But if you don't do anything, if you triage normally and said that person's a black tag because there's no respirations and no pulse, then you're losing the opportunity to resuscitate a lot of people.
Interesting. Okay, that's very cool. You can also get things like burst eardrums. You can get cataracts earlier in life than you otherwise would have, because it kind of fries your lens. And we can get these like burning kind of pattern, the Lichtenberg figures. These are some pretty gnarly ones. So you're tagged for life. Just key takeaways. We can run through these real quick. So classifying burns, superficial heals pretty well on its own. You have to reassess the patient again for bad burns 48, even 72 hours later, because the burns evolve and can end up being a lot worse than they look initially. You got to take their airway early if we're concerned for airway compromise. Well, there's some other good ones. Just really good pain control, because these are, extremely painful injuries. Remember the rule of nines, and remember that it doesn't apply as well in kids because their head is bigger. Fluids, the calculation is less important for y'all and even for us in the ED, but just knowing that they need to get fluids started, and you're not going to hurt them by hanging a liter on the way. For electrical injuries, I didn't really talk much about this, but the surface injury doesn't necessarily correspond to the extent of the deeper injury, and they can be a lot worse than they look initially as well. And then we talked about the transfer criteria, but thankfully there's TCC to help with that. That's all I got. Any questions?
No, great job, man. I appreciate it. It's always great to hear about these. These are low incidence but high risk injuries. And they're always devastating to everybody. These are just, you don't want to get burned. You know what I mean? A couple things. Remember, airway exam, airway management is super important to these folks. I know that the advanced practice guys can sedate and intubate, do RSI, resuscitative airways. A lot of folks can't. That doesn't mean you still can't manage that airway. If you've heard me say this once, you've heard me say it a million times. If someone has an issue that makes you think they could be hypoxic or they're critically ill, sick, they need oxygen. So all these burn patients are getting some O2 from you, right? There's no risk to giving them O2 unless they're still on fire. Otherwise, they can get some O2, right? If they have signs of an inhalation airway injury, that needs to be moving toward a hospital or to a trauma center as soon as you can. I would say know your local resources, so you know that if you as an agency don't carry cyano kit, you can't do advanced airway management with sedation and paralytics, and you got this guy that needs to go to the Mecca, whether it's Mobile or Huntsville or Birmingham or wherever, and you're a long way away, but they need an airway. Know your local resources to know that you can go to that ER. They can manage that airway for you with medications. They can even start that cyano kit, things of that nature, because you don't want to be going down the road 45, 50 minutes without an airway. Or if that patient needs a cyano kit for exposure, you don't want to wait 45 minutes, because if they have a significant cyanide exposure from a fire, they needed that medicine like 5 or 10 minutes ago. It's just like being hypoxic and not breathing and holding your breath. People don't do good. So aggressive airway management, things you can do to help bridge the gap till you get that advanced airway sometimes. If they got an inhalation injury and they're stridorous, you're going to be doing your nasal cannula O2 at 15 liters. You're putting your non-rebreather over there, and maybe you're breaking out some racemic epi and nebbing that around that non-rebreather as well to bridge the gap from that swelling till you can get them intubated. We talked about fluid resuscitation already, and then he mentioned hyperbarics. Hyperbarics in the deep south are challenging. UAB can dive you, but if you're critically ill, we cannot put anybody on a ventilator in our hyperbaric chamber. I think that Pensacola has one with the military, but it's if you can get in there if you're not in the military. And then I know that there's a, what's the hospital in Mobile that has one? Help me, anybody know? It's not USA, it's the other one. And we get blank stares. What now? No. All right. There's another one in the Mobile area that has a chamber as well that can do things. But if you need access to a dive chamber, two things to call. One, TCC. Two, there's a national dive chamber number you can call as well. Or three, the better option is figure it out right now so you know where you need to go with those people. So burns are very challenging to manage. It's a tough call for the patients. But you will see them sometimes.
So, Dr. Ferguson, I know for years and years, nobody in the Birmingham area was carrying cyano kit, mostly because it was cost prohibitive.
Right.
But I know Birmingham Fire's been able to at least have supervisors.
Right. So several places have got it now. I mean, it's about $1,000 per unit dose, plus or minus a little bit. That's expensive, but you don't need it on every vehicle, every apparatus, as you fire people say, right? You just need it in the department that can get to a location. So at the city of Birmingham, we keep it on our EMS supervisor's vehicle, and we keep it on the safety officer and then the battalion chief. So there's always one at every working house fire. So that way, if a firefighter needs it, we have it there. But we use it a lot for the citizens as well. We've had several cases where it's been very beneficial. There was the most recent one was a elderly female inhalation injury, some minor burns, altered breathing fast. SATs are 100%, but she's not responding to oxygen. So you got to think, why is this person that doesn't have major burns, altered period arrest, and working hard, but SATs are 100%? And it's either CO, right, or cyanide in that situation, right? So how do you treat CO? More oxygen, right? So it's high flow O2. If you can intubate them, you intubate them in high flow O2 and you manage that airway. Okay. And that's really all you can do for CO. If the O2 is not, and you treat that for the O2, right? So the next thing is you think cyanide, and the only way to treat that is with the cyano kit. So, and we've had some good cases. This lady got the cyano kit. She initially arrested for a few minutes, IV access fluids, iGel placement, and cyano kit, and en route to the hospital, she starts waking up and starts fighting and pulls the iGel out. So it's pretty amazing. It's almost like giving somebody Narcan or D50, or for the flight guys, giving somebody a paralytic. You get immediate gratification. It's amazing what it does. So it's good stuff. I know it's expensive, but my suggestion would be, if you are a fire-based EMS provider, you should have this for your fire service at least, right? You don't need a lot. You just need one that goes to the fires that you take care of. And if a citizen needs it, then you got it from them as well.
So you mentioned the flight guys. Do you know if any of the helicopter services carry cyano kit?
I do not. My guess is probably not, again, because of the expense. But it's for me, it's hard for me to say, if you're a fire-based EMS agency and you're going to be responding to fires, why don't you have this? At one point, this is going to get me in trouble, but I don't care. At one point, the distributor for the cyano kit in the Birmingham area from the manufacturer said that he would be willing to let you purchase the cyano kit from him, and before it got expired, he would exchange it. Now, I don't know if that's still a thing, or if that person is gone, or if he's going to like leave the state now, because I said that on this class. But there are ways to get that to make it work.
Yeah, just like too, the thermal burns on the skin looking worse later on a fire scene.
Yeah.
I've also, in personal experience, on a multitude of times, you have a citizen who was trapped in a smoke charged closed environment.
Yeah.
Come to you on the scene, and they have a raspy, hoarse voice.
Yeah.
I learned to pay very close attention to that, because oftentimes 15 minutes from now, they're going to be completely apneic and in cardiac arrest.
Yeah. Yeah. You got to be aggressive with the airway. If you think there's an inhalation injury, they have any signs of inhalation burns, you need to be aggressive and get them to where we can get an airway taken quickly, because if that swells, you're really hosed. The cyano kit's a little bit different. So if that person's talking to you with a raspy voice and they're confused, short of breath, if they don't look like they're dying, they could have an inhalation injury, but they don't have the cyanide poisoning. Cyanide will kill you quickly. So these people are sick as dirt, easy to recognize. It's the patient peri-arrest, cardiac arrest, no obvious signs of trauma, not responsive to your initial therapies. It's like, oh crap, this is probably cyanide. You hang the cyano kit and you get a response, and it's pretty cool.
Yep, very good. I'd mentioned too that on a lot of the life packs, cardiac monitors, if you have the rainbow sensor, the expensive SpO2 sensor, most of them will convert to SpCO at 5%, I think.
Yeah.
You can set it for whatever. So the problem with that is those sensors go bad and they're super expensive. They're about $1,000 to replace that sensor and cord. And so a lot of EMS folks revert back to the cheap fingertip ones. So if that's your habit, right, is you're carrying the cheap fingertip thing in your bag, but you still got the expensive one, but you don't use it because you don't want to break it, at a fire scene is the time to use the expensive one, or any time where carbon monoxide poisoning might be an issue, because it'll convert over and tell you
Right.
SpCO.
Right. And if it doesn't work or you don't have access to that, who cares? If your patient is symptomatic, short of breath, and you think they have this, give them the oxygen. It's not going to hurt, right? That's how you treat CO exposure, is with oxygen. So again, limited risk in giving somebody oxygen. Yes, if you give somebody having a STEMI or a stroke, high flow O2 for a day, you may get some free radicals, you may have issues. If you give a neonate a bunch of oxygen for a day or so, you may get some retina issues. But in the setting that you work in, the setting that I work in, there's limited risk to giving somebody oxygen, and there's a huge freaking potential benefit.
And like Dr. Ferguson said, I think it's super important to know where your hyperbaric chambers are.
Yeah.
For your own people, if you're a fire-based EMS, for sure. The other thing I've known, I don't have the data on it, just observationally, CO poisoning seems to be cumulative. And so we've had some instances over the years where we had firefighters that worked for multiple busy fire departments who end up working 5 24-hour shifts in a row because they swapped a shift or something, and they've been to structure fire or 2 every 24-hour shift, and you'll just see their CO level going through the roof and them really not being that symptomatic. So be aware of that. And hey, it's a bad idea to work that many shifts in a row and wear your SCBA. How about that?
Cool.
So great class, Dr. Holland. Appreciate you as always, Dr. Ferguson, Dr. Sullivan. Thank you. If you haven't already done so, please fill out an attendance form. Where are we going to be next time, Dr. Ferguson?
Enterprise, Monroeville with Enterprise. And then in July, there's just one class. It'll be up in Madison. And then we have next cadaver lab will be, I think, the second week of September. So
Awesome. Lots of great opportunities come up for some good EMS education and continuing education. Thank you, everybody, for being with us, and we'll see you next time.